Hello everyone. So in this video we're going to show you a ileal pouch for a familial adenomatous polyposis. So this is a male patient, young male patient with a low BMI. So we started the dissection always to we are going to perform a total colectomy or a proctocolectomy. We like to start in the right side of the bowel. So we started resecting the ileocecal vessels and ligating it. So it's our preference to do this way. So we think it's easier to go from the right to the left. So we will do this right side resection, so the medial to lateral dissection in the plane, in the Geraltus plane. Now we will find the duodenum. So we manage that. We now perform the uh, Toldt fascia on the right side and right column dissection. We go through it. So this is the epiplon, the larger omentum, the greater omentum. So we're resecting it and completing all the right dissection. Now we're going to the branches of the middle colic veins and artery vessels. So we ligate their left and the right. Now we procedure the dissection in the meso column of the transverse column, and we found that the pancreas. Now the right ligament, inferior mesenteric vein. So we are going to perform the ligation of the inferior mesenteric vein. There is no suspicion of cancer in this case of neoplasia, but we prefer to do this ligations on the origin. So now we're finishing the mobilization and the splenic flexure takedown. So here we are going to ligate the inferior mesenteric artery. So we are moving from the right side to the left side, already performing the transverse column. Now we ligated it and we put the artery up, and then we resect it to the posterior part where we're gonna find the ureter on the retroperitoneum area. Notice that the column is already without vascularity. So this is the left side and the right side of the total mesorectal incision. So we prefer even in inflammatory cases or non-oncological cases to perform the total mesorectal incision to go in this vascular plane, avoiding the nerve injuries, the hypogastric nerve injuries, or other plexus. So now we go to the posterior. We have to resect all the rectum because there was plenty of polyps in the rectum, more than 30 polyps, a lot more of that. So we're going to dissect the lateral, the left, and we finished. So now we're going to transect both the rectum distally and the ileum. So we are now resecting it. We're gonna perform a Pfannienstiel incision. So after we extract the specimen, we staple the terminal ileum. Then we will make at least 2 staplings with the linear 80 millimeters linear stapling to create the J-ileal pouch for this anastomosis. Then we will make this anastomosis with the distal rectum with a circular staple. So this is the final aspect of the diverting ileostomy, and the specimen with a lot of polyps, more than 100. and larger polyps on the left side, and also many polyps on the rectum. Thank you very much.